Afternoon. Good afternoon, everybody. Thank you so much for joining us. We are really excited to see everyone and get an opportunity to hear from our partners at the CDC. My name is Dominique McCoy with the To&Through project here at the Crown School in Chicago, and I'm going to be hosting our event this afternoon. A couple of quick announcements, reminders before we get started. We do have today actually kicks off our fall events for To&Through. So we do have a couple more events we wanted to remind you all about in hopes that you can join. On October 12th, we are going to be releasing in partnership with friends at the Chicago Consortium on School Research, our annual update on the attainment of Chicago public school students. This is an opportunity to take a look at some of the latest rates around high school graduation, college enrollment, and college completion, and provide us with some space to have continue our conversation just around opportunities and access to higher education for Chicago public school students. So please join us if you're available for that. November 9th, we'll be hosting another one of our in-person tool workshops to provide you with an opportunity to learn about our publicly available CPS data tool that exists on our website, to provide you with an opportunity to kind of understand all the tips and tricks, get an opportunity to sit down with some of our team to help you navigate thinking through how you can put some of this data into action. So if you are available to join us for that, we would be excited to see folks in person again. That is going to be hosted by our friends at Bottom Line in the on November 9th. And then finally, we have another research report that's going to be coming out in December 5th that will be looking at some work that our team has been doing around CPS students' time to completion, looking at the differences between 4-year college completion rates and 6-year college completion rates for bachelor seeking CPS students. So excited to share some of that upcoming research with you all. If you're available to make it, there should be links in the chat for you to RSVP, and we're looking forward to seeing those of you who can be there. A couple quick logistics notes before we get started. At the bottom of your screen, you should see a small button that says Q&A. We very much encourage you to submit your questions as we are moving through the presentation today. We are going to be holding time at the end of, towards the end of our hour together here today to passing those questions on to our friend George, who's going to be presenting with us, and get an opportunity to dig through those. So please keep those coming in, particularly as the presentation is going on. And then finally, for those of you who RSVP, there should also be an invitation on your calendars to join us for our post research spotlight discussion. And so these are some space that we put aside really in response to feedback from many of you all who attend our events, who asked that we could try to just have some more collective space to make sense of some of the information that we get a chance to hear about today. So if you are interested, please join us. We will be transitioning to a separate Zoom room. We'll put that information into the chat at the end of this hour. So if folks that are interested can transition over with us, and we can get an opportunity to continue the conversation. Just talk through some of the takeaways that folks are leaving with today. But with that, we will just get my notes up here. Without further ado, I'm really excited to introduce Dr. Jorge Verlenden from the CDC, who's going to be joining us to share some of their really amazing research they've been doing in our young people across the country. Before we jump in, George, I gotta let you stand in your shine a little bit. I want to share some information about you. So Dr. Jorge Verlenden is a health science with the Division of Adolescent and School Health at the Center for Disease Control and Prevention, where she focuses on the development and evaluation of school-based programming to enhance the health and well-being of children, youth, young adults. George spent her early career working in educational development projects in Cairo, Egypt, and Amman, Jordan, and working with forcibly displaced children from Sudan, Somalia, Eritrea, and Ethiopia. She has taught individuals across lifespans from early childhood to older adults and trained educators in nationally and evidence-based practices that foster academic success and psychological well-being. George earned her doctorate and master's degrees in psychology from Tulane University. Has completed a postdoctoral training at Morehouse School of Medicine with joint appointments in Georgia State Center for Leadership and Disability. George, we are incredibly excited to have you with us today. And with that, I will pass it over to you.
Thank you so much. I'm delighted to be here, very much. Thanks for the introduction and the extended description. I actually was just thinking with my mother, who is 89, about my journey into this position, because it's been kind of a long one, but it's been a glorious one as well. And so I'll start off in a way to just introduce myself in kind of a personal way, because I've been doing work with kiddos for a really long time, and it brings me joy, sometimes heartbreak, and it's been part of my path of growth, and up to my now 56 years of being on this planet. And so as Dom mentioned, I started my early career working with young people in Cairo, Egypt. Right out of college, I took a volunteer job working there for an international refugee group, and I taught English as a second language and worked with a host of kiddos from various countries. This was, just in the aftermath of a number of civil wars in the MENA region and then Northern Africa. And so there were many forcibly displaced young people from Rwanda, from Sudan, Somalia, Eritrea, and their intensity, their hardships, their willingness to accept me and as someone to support them, that really supported me and along my path to become a psychologist and to be here today as a health scientist with CDC. I loved working with those kiddos and their families, and then trying to leverage all the supports that I could to enable them to make the next steps to stability. But then, of course, those personal experiences, they brought up a lot of questions in my mind as a youngster, as a 26, 25-year-old youngster, so to speak. And I started going back to school to try to answer those questions and try to understand things that we now, talk about as social determinants of health and inequities and the drivers of disparities. And so I have not come to any solutions or grand understanding exactly, but to know that it is an important commitment that we have as public servants and individuals who want to do something to enhance the world a little bit, is to really face how disparities occur and the systemic factors that drive them, and do what we can to make the changes along the way, and then to lift up children, adolescents, young adults, families, etc., in any way that we can. I came to CDC after years and years of working with kids and families and so on and studying, because I really wanted to try to even leverage more advocacy leverage my knowledge of math and science to be able to do more data analysis and to understand things on a broader scale and looking at patterns. And so I joined CDC about 5 years ago, and it has been a whirlwind of learning, but also of excitement. But then also, as I mentioned, sometimes sadness and hardship. The data I share today, points to some of that, because even after my 2+ decades of working with kids and youth, a lot of the same things are things that we see now, that I saw then when I was working with migrant kiddos and refugees. I see these same things in other communities, but then I also have seen some extraordinary resilience, and those bits of hope give me a sense that there are things that we can do. So I won't talk anymore about myself, and I will work here to share my screen and talk a little bit about the work that we do in the Division of Adolescent and School Health. So I'm going to look here. I think that's almost shared there. And I'm going to put this in presenter mode, so screens will be perfect, I think.
Yep.
Does it?
Yep.
Great. Okay, so here we go on this research spotlight related to adolescent mental health and well-being. So I want to acknowledge immediately at the very beginning that anything that I'm presenting today, this work necessitates a lot of work of a lot of other people. I am just part of that process as a public servant. The public health professionals across the Division of Adolescent and School Health lead the data collection efforts, conduct the research and evaluation, and support the implementation of programmatic work that will be highlighted today. And I am honored to get to be a part of that and to represent that with you all. However, also the findings and the conclusions and any ramblings in this presentation are those of the author and do not necessarily represent the official position of the CDC. So to kick us off, I'm giving you the bricks up front, the takeaways straight away. So today, I'd like for you to leave with an understanding that CDC's Division of Adolescent and School Health is committed to promoting the health and well-being of students and to helping schools do the same. These national data that I'll share illustrate that the mental health needs of youth really can't be ignored. And the striking disparities that you'll also see necessitate action to eliminate the inequities that drive this. So I'd like to tell you a little bit about CDC because we often get the question of whether, what do we do related to adolescents and health and mental health and schools and so on. So the Centers for Disease Control and Prevention really strives to address a myriad of health situations, health conditions, reducing risk for death and disability and poor health outcomes. Related to youth, CDC strives to help youth, be healthful and healthy and make healthy choices and be successful. We envision a future where all youth in the U.S. are equipped with those knowledge, skills, resources that enable them to be healthy adolescents, but then also help them become healthy adults. In DASH, we take a particular public health prevention approach. And I'm going to talk in threes a lot today. So there are three core functions in DASH's public health prevention approach. We collect and analyze data, and that is kind of the bread and butter of a lot of the CDC work. The youth risk behavior surveillance system is one of our primary data collection instruments, and I'll talk about that data today. But we have other data as well, including the school health profiles, which as an organization yourselves that's really interested in the work of schools will likely be quite interesting to you because it contains data on school health policies, programs, and practices. Along with collecting big data, we conduct research and evaluation. And that research is really focused on emerging health issues, new interventions, very specific populations of adolescents. And then we turn all of these things into the support and implementation of primary prevention programs. Much of our work is funded to prevent and reduce incidents of HIV, STDs, and unintended pregnancy, but along with that, other chronic conditions, including mental health, poor mental health, but then also other risk factors and behaviors such as unintentional injury. And DASH, the Division of Adolescent and School Health, we really lean on this understanding and belief that school-based work is effective. Youth spend much of their days in schools, and we know that that is both where they are and an avenue for supporting them. But schools have to have the capacity to be able to do that. But when they have that capacity through effective prevention strategies, they're able to improve the health outcomes of students across age groups. So we really focus in 3 areas: delivering quality, inclusive health education, increasing access to appropriate health services, and promoting safe and supportive environments. When I talk about the delivering quality, inclusive health education, that's across age groups. So across K-12, developmentally appropriate health education enables students to build understanding of themselves as humans, and enhances their skills for action, to be able to take care of themselves, to be able to act upon their needs, to be able to self-advocate, but then also to be able to understand risk involved with certain behaviors. When it comes to our work with increasing access to appropriate health services, we do that in a myriad of ways. We focus on school-based health work, wherein we help schools build the capacity to either deliver school-based health services, including mental health services, or link students to appropriate services in the community. And when it comes to promoting safe and supportive environments, we really focus on those foundational wraparound components of the school environment, building the capacity of the educators to create the safe and supportive environment, but then also helping schools think about the establishment of initiatives that build up the skills of students and bring them in to be more connected and engaged in the school community. And we do this through a variety of ways, through youth advisory councils, through gay-straight alliances, through a variety of inclusive practices to enhance restorative and positive behavioral practices in the classroom. But I know today that you all are really interested in our data. So I want to give you a quick overview of the where this data is coming from that we'll talk about. Primarily, I'm going to focus today on the Youth Risk Behavior Surveillance System. That data system was established in 1990. And we use it to monitor health behaviors and experiences among U.S. high school students. these students report themselves. So youth are reporting through a variety of means, primarily pencil and paper, but we are, with the times, morphing into digital formats, in which students have this opportunity to respond to questions, to tell us what their experiences and exposures to risk and adversity, but then also protective factors, what those look like. YRBS is actually the only federal surveillance system to provide representative national and state data of youth that can help guide decision-making. And I'm hoping that through your breakout sessions, you might be able to consider looking at some of that state and local data for Chicago and Illinois. Just recently, in the spring of 2023, we released the Youth Risk Behavior Survey Data Summary and Trends Report. This report provides an overview of data on key health indicators, such as mental health and suicidality, sexual behavior, substance use, and experiences of violence. This report is a synthesis, so it provides a synthesis of information. We also have more in-depth reports that go into detail and look at the associations between reported exposures and experiences, and then other outcomes. So I'll begin touching upon the key bits of data that I felt that based on my conversations with Alex and Dom and yes, we thought that your teams may be the most interested in today, to be able to spark some thinking. What I have here on this slide is a depiction of the indicators from the YRBS related to mental health and suicidality. Now, just in general, the mental health challenges experienced by many high school students are reflected across 10 years of data. And those are reflected here on this slide. And I'm not sure that my cursor is showing across these things, but I will talk you through. So at the oh, you can. Okay, yeah. That's fantastic. So over here to the right is a simplified legend in which we have these trends, the red trend indicating that, that there's an increase going in the wrong direction. The yellow indicating that there's not been a particular change, and the green indicating going in the right direction. So meaning that, when we're seeing increases, it just simplifies the ability for us to look at these data across. So at the top, I have here, like the percentage of high school students who, you see that particular question, starting on the left with 2011 and then going through 2021. YRBS is administered every other year. And so the data across 2011 to 2021 is in an every other year cycle. This, you'll see here that indicators of poor mental health, such as experiencing persistent feelings of sadness and hopelessness among youth, is an indicator that has for years been high. In 2011, 28% of high school students reported having felt so sad or hopeless over the last year for 2 weeks and more that they stopped doing their usual activities. And in 2021, 42% of students were reporting that. And you see that that has increased over time. Likewise, you'll see these other indicators: seriously considering attempting suicide, making a suicide plan, attempted suicide, and then also being injured in a suicide attempt, all have concerning patterns. But I'd like to move forward here to our most recent data and show you some information that's more granular and parses apart the data by demographics. And part of the reason that I feel this is especially important is that when we're trying to make decisions and call individuals to action and think about what we need to do with such data, we actually have to begin taking it apart. And in a way, for me, even when we have a really distressing number, like 40% of high school students having felt so sad or hopeless, when we have a number like that, in order to tackle it, we have to start looking at the disparities that are apparent in order to see who is the most impacted and how can we begin supporting those students in order to reduce these incidents of poor mental health. And so on the right, I think very clearly you can notice that there are, some stark differences in females' report of sadness and hopelessness, stark differences in LGBTQ students' report of sadness and hopelessness when compared to heterosexual youth. And then likewise, among the race, across race and ethnicity here, you can see patterns that I believe as researchers and policy advocates and so on will cause you to ask questions of why and what might be causing, say, 46% of Hispanic students to be reporting such an indicator. I'm going to go on to the next point here because a second indicator of poor mental health related to attempted suicide also reveals striking disparities in populations. So more than almost double than the percentage of females have attempted suicide in it reported an attempted suicide in 2021. So 13% of females reported an attempted suicide compared to 7% of males. I don't want 7% of males to be attempting suicide, but it is striking also that more than, that 2 times the number of females have done so. And so considering what sort of driving factors may go along with that is where we can consider what our actions should be. Likewise, with LGBTQ youth, 22% of LGBTQ plus youth attempted suicide in 2021, compared to 6% of heterosexual youth. You can also see potential disparities across race and ethnicity. And then later, when you are able to dive into some of these data independently, you'll begin to explore and see how there may be intersectional factors as well. I want to also highlight, when we think about mental health and well-being, that there are a number of other risk factors that are associated with poor mental health. We know that many high school students use substances such as alcohol and marijuana or misuse prescription opioids. I do want to note that, as I explained earlier, the trends, many of them are what we would say are going in this hopeful direction where there are reductions. However, these numbers are still high, with 23% of high school students drinking alcohol, 16% using marijuana, the percent of vaping, as well as ever misusing prescription opioids. But this very full slide, this is where you can begin to really look at where the differences lay and patterns that indicate that there may just be disparities in substance use that could drive some of the mental health indicators that we saw earlier. So some of the notable differences, these various patterns, relate to race and ethnicity and use of alcohol and those differences across racial groups, as well as use of marijuana and the misuse of prescription opioids. When we look at differences by sexual identity, by race and ethnicity, and by sex. I do want to remind people that when we think about disparities, we also have to think about what drives those disparities. So considering the social and environmental factors that create inequities that end up creating situations that may result in the disparities that we see. I'll also point out here another related indicator of poor mental health and well-being has to do with the experience of violence, either direct or in one's community. Too many students are experiencing violence. And the data that I have here reported on this slide is more related to an individual experience of violence as opposed to a community experience of violence. But we see here that the trends related to being threatened at school or injured with a weapon, not going to school because of safety concerns, being electronically bullied, being bullied at school, ever being forced to have sex, experiencing sexual violence by anyone, that most of those remain notably high, even if we might think that we might see a reduction, something going in the right direction, and I do celebrate those indicators. However, still we have 15% of students who reported being bullied at school and 9% not going to school due to safety. And then when we look at such indicators a little closer, we begin to see the disparities that begin to help us think about what is going on and who is the most impacted by these exposures to adversities. So LGBTQ students experience more violence than their heterosexual peers. 27% of the LGBTQ students reported experiencing being electronically bullied in 2021, compared to 13% of heterosexual students. 14% of LGBTQ plus students missed school due to safety concerns, compared to 7% of heterosexual students. I would like to see no one missing school due to safety concerns, but these particular figures here make me wonder what it is that is happening within the school environment, for example, that might need to be changed in order to ensure that we have a safe and supportive environment for students at risk for being bullied, at risk for any sorts of threats and such. Likewise, when we look at race and ethnicity, we also see that students, there are patterns that suggest inequities here. Black students, Hispanic students, Native Hawaiian and Pacific Islander students, multiracial students, American Indian and Alaskan Native students, all reporting fairly high percentages of ever being forced to have sex. These are numbers that we have to think about, and think about what inequities exist that may result in these higher numbers for some populations versus others. Now, the numbers that I just went through are very broad and focused on a national level, and they're really just a snapshot. And I'll be able to provide a PDF of these slides so you can have a look at those particular numbers with ease, as well as links to the data trend summary where those numbers and charts exist. Also, there are a number of longer report supplements that include topics related to school connectedness, parental monitoring, witnessing community violence, experiences of unstable housing, experiencing suicidal thoughts and behaviors, the role of COVID on sexual behaviors and receipt of sexual and reproductive health services, dating violence, sexual violence, bullying and victimization, dietary and physical activity behaviors, as well as alcohol and other substance use before and during the pandemic. We have longer supplements that incorporate a deeper dive into these particular content areas and pull the data apart a little bit further to describe the exposures that that youth reported in 2021. But aside from having to, say, read the data trends report and review various supplements, you too can dive right into the data that we have through the YRBS Explorer. I know individuals at CDC know individuals at DASH, and that data can inform action. Data can be really actually powerful information that can leverage support for a variety of initiatives. And because of that, one of the tools that CDC provides is a tool that allows individuals and the public to be able to easily dive into data. And so the YRBS Explorer provides like visualization of YRBS data and allows you to search for specific topics or questions, to compare data across locations, and to review details from a specific year, as well as to create tables and charts. And you can do that. I just looked right before this call. You can do that for the Chicago area. You can do that for Illinois. You can do that for neighboring states. And then begin thinking about how do the experiences of youth in general in your area, as well as specific populations of youth, how do they fare? What are they saying? And then to be able to tailor interventions and prevention strategies to meet those needs, to fill the gaps in health services, to fill the gaps in safe and supportive environments, and to ensure that students and young people have the health knowledge that enables them to be, health literate and empowers them into action themselves. So I sit here for just a moment to close before we go on to your breakout sessions and discussions with this image of young people. I mentioned that I have worked with young people for a long time, 2 decades. And each time I look at numbers, I really try to not just see those as numbers and dots on a screen or directions or associations, but I think about all the students that I have worked with, all the students who are now young adults or older adults, even, maturing adults after 20 years. I think of them, and I think because I have worked so often with students who may have previously fallen through the cracks or on the margins, and seen them thrive through support, that facing the unpleasantness of these numbers in which you see hardship and diving into understanding gives you and students the opportunity to be understood and their situations understood, and then leveraged into new opportunities. And so I think of all of the students, the Ames, the Isaiahs, the Amins, the Yusufs, the Nikhils, the Nikoses, the Penelopes, the Alias, and so on, who have blessed me with their youth and reached out for support to be able to gather the skills to succeed. And I am appreciative that you all are here today to be able to think about how you and the work that you do in schools, building the capacity of schools or building the capacity of youth, how you will be able to use these data to inform the actions that are necessary, that all of this data and the disparities, these striking disparities, call us to, because that is where we are now, where the data can't sit there. It has to be something that we do something with. So thank you very much for inviting me. And I'm happy to answer questions and dive in deeper to particular things. All right.
Thank you
Thanks,
so much.
Tom.
I'm back. Before we let you go, we do have a couple of questions that we did want to jump into before we close out for this portion of our presentation. But to start, one, folks, please continue to submit your questions so we can try to get to as many of these as possible. But to start things off, at the To&Through project, we also provide data. We try to be really clear when we use particularly our quantitative data. Try to be really clear with folks, like you mentioned, that this is really a starting place, right? And that we really hope that this, when folks start to interpret some of these findings, it really launches into deeper conversations or deeper explorations to really understand how to respond for students. And I'm curious, from your perspective, has there been stories or kind of use cases or examples in your time in this work where you've seen organizations or leaders or educators really use this data that particularly stuck with you, and some of those use cases that have really inspired you, how people have put some of this data into action?
Yeah, okay, I won't, I don't have permission to use a particular school district today, but I will highlight one district that we are working with right now, and I'll describe some of the work that they're doing. They are a large district, and they are not in the Chicago area. This, although we do work with the Chicago area, but this particular district is, they utilize the broader YRBS data to start thinking about how their students at the school level, at the local education authority, how their students compared initially. And one of the striking things that they found, this particular school district, were that many of their students were faring poorer. There were students, their numbers were were, oh, were worse. And that was really distressing to this particular district. They're a big district. They have a lot of people. I will not say that they are a well-funded district, but they do a lot. They are trying to get a lot of programs into place, but they struggle in these particular ways. They used this knowledge of how much students were struggling due to a lot of economic insecurity, a lot of migration of student population, a lot of housing insecurity amongst their student population, especially amidst the pandemic during this hardest hit period. They use that to be able to advocate for additional funds for a variety of things, for mental health personnel, for social work personnel, for school nurses. And so they were able to not just think about, okay, we need certain initiatives, although I will tell you one of the initiatives that they did choose to put in place, but they also were able to show that they desperately needed to enhance their institutional capacity by building up their staff. And one of the bits of data that they did utilize related to connectedness, school connectedness, and it is a variable that is on the YRBS now. And we talk about the potential of school connectedness as a buffer to stress and adversity, and ways in which that those connections to a caring adult can be that. And in this particular district, their students on a school and local level survey, something like a school climate survey, there were a large proportion of students who reported to the school that if they had a hardship, they didn't know who to turn to in the school community. They didn't think that teachers knew their names. Now, I'll share a personal story about that with me, that my family is from Louisiana, and we lost our home to a fire, and we lost everything. It was a terrible, catastrophic situation, and there was a lot of upheaval. My family is a working family. My dad was a teacher. My mom was a forest firefighter. That's quite a story, but I digress. When we lost our home to this fire, I was a middle schooler, and I was embarrassed because I had to wear, the same shirt days on end, and we were for a period of time staying, in various semi-motel like situations, so partially, definitely unstable home. And the middle school secretary invited me to stay with them, and it was a family who I needed that lift up and that connection to this particular person, and that I knew her already, that I trusted this person already, that that connection and that feeling that the individuals in your school, that there is someone you could go to for assistance, is an important one. And so in this other school district, when their lead of all of their mental health initiatives had this data come back in which their students were saying that they didn't have anyone in the school environment that they could turn to, that presented an opportunity for them to say, we have to make a change, and for them to begin implementing foundational connectedness focus projects for this school year.
Mm-hmm.
And so they use both of those, the data and then this importance and so on to call into action.
Thank you for sharing that. We had a couple people kind of noticed there was on some of the slides, there was a labeling of using LGBTQ as opposed to LGBTQ, which I think most people are kind of more familiar with.
Yeah.
And curious of, was that an intentional choice? And is
It
there data on
is,
trans
it
students
is.
specifically?
In these data, no. In these data, our questions were not able to incorporate trans youth.
Okay.
In the future, however, in the next iteration of our data, it will. And national data is such, and development of a national data instrument is a complex process that results in many stakeholders reviewing questions and determining whether whether they actually capture what we think they're going to capture, they're valid, they're reliable, and so on. And our questions related to gender, sexuality have been questions that we have been working on through the last decade. And our questions related to transgender youth have been more solidified, and we will see that data in 2024.
Thank you. I think a lot of us are looking forward to looking at the YRBS dashboard and digging into some of our more local results. But just out of curiosity, I'm not sure the last time you took a look at it, but for Illinois or Chicago, or kind of more large urban districts, is there anything that you think is worth folks paying particular attention to, or any trends that you think are particularly important to explore?
That is a good question. I'm going to throw it back to you, because it's the question that we always have to ask ourselves. It's like, what's important? Well, everything's important. However, we have to start to, you all know what the lay of the land is in Chicago, and the demographic intersections that generally experience the most risk. Yeah. And diving in there first to see how those kiddos are doing is a good start. And then not just looking at the negative, which, primarily I was showing those things, but then also looking at the protective factors, looking at parental connection, looking at school connection, looking at those things to see if there are levers for change, as well as, physical activity or health education. So looking at those youth that you already have a feeling that may struggle due to all of both historical and current inequities, then looking at them and these particular areas can help you make those decisions. And I think that is one of the ways that I would suggest going forward.
I appreciate that. Coming up on the last question, but maybe we can close out on this. I think the data tells a pretty clear story that it's a tough time to be a young person. I think you also have an opportunity to see a lot of the ways that folks are responding to that across the country. And so in this work, what gives you hope?
Yeah, that's a good question. I tell you, that's why I started off with like admitting how old I was and talking about how long I've been doing this, because it's like, gee, I'm still at it. Because I do have hope, and perhaps I'm eternally optimistic. However, there are areas that you would not believe are making comprehensive health education, part of their, part of the K-12 curricula. There are some districts that may surprise you that are requiring that their teachers be trained in mental health first aid. That's great. And so there is an initiative there on those particular levels. And then as well, I believe in young people. They are awesome. And I think that they bring, they're resilient. Really, humans are resilient. And I believe in them. But I also realize that because the young people today they're aware of all the things that are happening all across the world. Whereas when I was a little girl, I didn't know what was happening across the world. We didn't have that kind of exposure at all. And young people are aware of those things because that's part of their developmental responsibility to become actively involved in society. And that's a burden for them. And so they're taking it on. And I see that as hopeful, because when I am working with young people, when I get those calls to do an evaluation or what have you, and I sit down and talk to someone who is actually really suffering, they're so aware of injustice and they're so aware of things. So I think that is both distressing but full of hope, because I think that we can leverage their attunement to be able to make the society and a better place. So
100%. I absolutely appreciate that. Thank you. We are at time. Please go quick. For those of you, first and foremost, though, just on behalf of everybody, if we were in person, this is the point where everybody would be clapping and giving you a huge round of applause. Just so thank you on behalf of everyone for joining us today, for sharing this incredibly important work that you all are doing. And in some ways, I think, giving us the data to create less space to explain it away, right? To really try to address that and try to have some responses. So thank you. For folks that are interested in continuing the conversation, there is a separate Zoom link in the chat here. We are going to close this room in a moment, pop over and have a little time to debrief folks that are interested. But again, thank you all for joining. Dr. Verlenden, thank you so much for joining us too.
Thank you so much. I'll briefly pop into the next Zoom and I'll drop in some of the links that I mentioned. So you'll be able to kind of get into those early on, and then we can continue any discussion down the road.
Fantastic.
All right. Thank you so much.
Thank you so much.